Hello guys, my name is Carlo, also known as Dr. Sukos. I'm a final year medical student studying in Nigerian University, and my fourth Mbbs professional exam, I met through distinction in Paediatrics, distinction in obstetrics and gynecology, and distinction in community medicine. And if you've ever wondered whether distinctions are about luck, talent, or strategy, still me, because I'm about to show you guys how exactly I did it. So in this video, I'm going to be talking about how I made the distinction in Paediatrics. First and foremost, without wasting much of time, one, collect lots of cases. One of the biggest reasons I made a distinction in Paediatrics was simple but powerful. I collected a lot of cases consistently and intentionally. Paediatrics is not a subject that you can master from slides alone. Children don't always present by the book. So the more patients you see, the sharper your clinical acumen, the sharper your clinical instinct become. Now, every child at lab taught me something new, how symptoms evolve, how mothers explain the illnesses, and how the signs differ across ages and from patient to patient, and how theory translates into real life. Clicking helped me move beyond memorizing diseases to understanding patterns. My history taking became structured, my examination became more confident, and my differentials became more logical. Most importantly, clicking prepared me for the exams even without me knowing or realizing it. Long cases don't feel intimidating because I have done those things repeatedly. I've clicked a lot of patients repeatedly over and over again, and there was nothing to worry much about. In fact, the long cases I had in my exams were one of the best part of the examinations for me. You know, questions and written paper felt familiar also because sometimes you write your essays with what you learned in clinical and you apply those things also there. Now, in pediatrics, exposure is everything. The more cases you clear, the more pediatrics starts to make sense to you, and you have more in-depth understanding of what the examiners want, and they will reward you with distinctions if you merit it. One thing that really helped my mindset in pediatrics is understanding that the examiners are not primarily looking for a perfect diagnosis, and they always tell us this in clinics. Now, what they're assessing for is how logical your clinical reasoning is. How do you think? It's not about your conclusion, it's not about your diagnosis. They want to see that you can take a proper history, you can perform a proper examination to identify the problems, and you can logically work your way through the whole differential diagnosis to arrive at the one that is the most likely diagnosis, and of course, how you tend to manage these patients. So in pediatrics, children don't work with labels. They won't come and tell you I'm having pneumonia, I'm having severe malaria and stuff like that. You know, sometimes symptoms and signs can be subtle, and there might be one particular sign or symptom that you can elicit that, and there can be one particular symptom or sign that elicit signs that can give away the diagnosis. We can see that maybe let's say severe malaria and pneumonia might still be having the same presentation, but there might be some things from your history, from the examination that you elicit that you be like, no, I don't think this is severe malaria, I think this is pneumonia, and otherwise. Examiners know this, and that's why they are far more interested in your approach to your diagnosis than your final diagnosis. So even if you miss a final diagnosis, but your history is well structured, your examination is thorough, your differentials are reasonable, and your management plan is logical, they will surely score you well. So please, guys, if you're looking for a distinction in pediatrics, don't just be staying in the hostel doing nothing. Click a lot of cases. I usually click like 3 times a week. So I'm not always consistent. Sometimes in a week I'll just click like 1 case, but I try as much as possible to click every week. From the time I started my posting till when the exam started, even before we started writing the exams, I tried to collect as much patients in the world as possible before they finally banned us from coming to the world. So you find out that your exam day, most of all the cases, you must have been familiar with them at some point in time. So yeah, that's that. Please guys, click. Okay, another major reason why I did well in my pediatrics was that I learned how to answer questions. In pediatrics, most questions are framed as clinical cases or scenarios, and these scenarios are never random. There are always clues that are hidden in the questions that point or give away the diagnosis. So the questions are more like pattern recognition. If you're able to recognize this pattern, you can be able to hazard the diagnosis. And once you feel the diagnosis, every other thing that you're managing and investigating is going to be wrong, even if they are the same thing, because it's as good as you have killed the patient, because your major role as a medical doctor is to make a correct diagnosis. And we are doing investigations to confirm your diagnosis. And the questions are never going to be confusing. If it has to be severe malaria, it will be severe malaria. If it has to be bronchopneumonia, it will be bronchopneumonia. If it has to be anything, it will be that thing. There is always something that gives away the diagnosis. Details like the child's age, the onset of symptoms, the duration of symptoms, whether it is chronic, whether it is acute, the sequence of events, associated signs and symptoms, even some physical findings that they might even put in the question will always give away the diagnosis. For instance, okay, what will I use now? Let's say a question describes a child with a pansystolic pneumonia that is heartbeat at the left lower sternal border, associated with bowel weight gain and recurrent chest infection. That combination is already pointing towards the ventricular septal defect, if you know what I'm talking about. That pansystolic pneumonia is a giveaway, although VSD is not the only thing that will pansystolic pneumonia, but that's a very common finding here. And examiners are not expecting you to guess randomly, they expect you to recognize it and connect it to the diagnosis. So what the examiners want to see is not a magic diagnostic skill, but pattern recognition and logical thinking. So if you can be able to identify these clues, then differential diagnosis and build your answers around the most likely diagnosis, you will score very well. That's just that. Now, when you make your diagnosis in pediatrics, always back it up with your reasons. Yes, always back it up with a reason. Now, when you make a diagnosis, or let's say a child has acute gastroenteritis, reason being this, from the question, like derive your reasons from the case scenario that they painted. I wish I had my past question. I would have just used them as an example, but I believe that you should know or you should relate to what I'm talking about. So you can say, oh, I think the diagnosis is severe malaria because from the biodata given from the question, the child is 3 years old, and severe malaria is one of the commonest diseases or commonest infection affecting children under the age of 5. Yeah, and this child is 3 years old. He fell within the age. Same thing with things like nephrotic syndrome. They are usually age range. So it's same thing with acute glomerulonephritis. So the biodata, the age always give away the diagnosis and stuff like that. And of course, there is fever, there is this, there is that, those clinical and laboratory components of severe malaria, the ones that are present in the questions, you can bring them out to use and support the diagnosis. So when they ask you what is your most likely diagnosis, give reason why it is your most likely diagnosis. That's why you get a good mark. And when you ask for other differential, also give reason why you think that these are your differentials, but it is not the most likely diagnosis, that kind of thing. So that's that. And of course, whenever you're investigating, always tell them what you are expecting to find. A good doctor knows why he's ordering for various investigations. You don't just say, I want to order for a food lockout, I want to order for this, I want to order, but you don't know the reason why you're ordering for them. So whenever you are writing an investigation, always tell them why you are ordering the investigation, or the possible things you're expecting to see. For instance, there could be anemia in severe malaria. You're expecting to see anemia. That's what you want to rule out. You want to do a random blood glucose to check whether there will be hypoglycemia, because severe malaria can give you hypoglycemia and all those things. I'm not teaching you guys severe malaria, but I'm trying to tell you guys that whenever you write investigations, even in long case, whenever you are telling them about your investigation, don't let them ask you why are you ordering for this investigation. Any investigation you see, tell them straight up. I remember in my long case, I rattled from the biodata down to my management, to my conclusion, and my examiners never stopped me. They never stopped me because I was in sync. I was saying the right thing. I wasn't waiting for them to tell me, why are you doing this investigation? And the rest of them. So, yeah. Then, of course, even in your physical findings, in your physical examination, tell them, starting from the most likely system that was involved, from the signs and symptoms, giving the question, examine that system thoroughly, tell them the things you are finding, what are the possible findings in your system. That way, they are very happy. Sometimes it seems like pediatrics is hard because most of us don't do the right thing. You just feel like you just write anything and then you go, no. Please, if you have not learned how to answer questions in pediatrics, I think this can be a guide. I don't want to speak more on it, but I'm just giving you always tell them the reasons for every single thing you are doing, from the making of your diagnosis, your examination findings, your investigations. Yeah, that's for the second one. So the next tip I'm going to be giving you guys is for your long case, and it's about the sequence and the flow of events. I'm very pretty sure a lot of schools still do long cases in pediatrics, at least my school still do, and I know some couple of schools that still do long cases in pediatrics. Now, they have to be very sequential. So you should be very courteous, right? You should start with your biodata, and of course you know the details of the biodata. I'm not coming to teach you guys how to click. Then of course you know your presenting complaints and the durations, you know your history of presenting complaint. Now you have to be very thorough in your history of presenting complaint. It has higher mark if they are awarding you, because that's where majority of the diagnosis will be based on. Like, at least by the time you are done with your history of presenting complaints, 70 to 80% of the diagnosis should be made. So you must exhaust your 5 and the 6 C's, all of them. Then from there, talk about the past medical history, talk about the drug history, then talk about the prenatal, natal, and postnatal history. That's the birth history. Then talk about the nutritional history. Why is that so? Because there will be births before nutrition. So you shouldn't be disorganized, and in your history, you are just clicking randomly. The person will not follow it chronologically. So after your birth history, the next thing I should come in is on nutritional history, because after the child is giving birth, though, the child has to feed. And of course, the child has to be immunized. So you talk about the immunization history. Mention the immunization the child has received to date, where this immunization given. If the mother has the immunization card, mention it. If the mother doesn't have it, mention that you asked, because that's the best evidence that the child was immunized to date. Talk about the developmental milestone. Now, one thing students feel is that they only talk about the gross motor skills. Now, developmental milestones has domains, right? We have our gross motor scale, we have our fine motor scale, we have our social, all those things. So just make sure that you touch each of these domains. Don't just focus on gross motor skills. These are things the examiner is expecting from you. Then, of course, talk about the family and social history. With the child in context, what's the position of the child in the family? Where does the child go to the toilet? Where does the child sleep? Who does the child sleep with? All those things with the child in focus, that particular child you are correcting. You're not telling them about other persons. So the other people you're talking about is in relationship to this child. talk about your review of his review of systems, starting from the most likely system that is affected, but try as much as possible to review all the systems, about 8 of them. Then talk about your general physical examination, examine the child generally, take your vital signs, and do your anthropometry. And when you do anthropometry, please relate it to the CDC or the WHO chart, depending on the one you guys use in your school. Many students don't even know about the WHO chart. I think I was talking to one of my friends a couple of times, and I told him about the chart. I was like, "What's this? I've never heard about it." And he was about taking his pediatrics main exams. So please, there's no policy CDC chart. That's it. All your vital signs, in fact, everything that has value in pediatrics, you have to relate it to the CDC chart. Tell them whether it is normal for age, for expected age or not. If you don't have it, you can use there are formulas in pediatrics that you can use. For example, let me not just give you guys these details, but the best is actually using the CDC chart. We chart it, we check the percentile it's filling, know whether it is above, below, or within the normal for expected age. So when you're putting all these things, you'll be like, the child's weight is 15 kg, which lies at the 50th percentile and is expected for age. That kind of thing. The examiner will be nodding that, yes, this is actually what I need. Do you understand? So next is you do your systemic examination, starting from the most likely system that's involved, and try as much as possible to examine every other system, right? Because you can find other things from other systems that you don't even know, but I didn't pick out in your history. Then from there, you talk about your diagnosis, your differential diagnosis. I've already told you guys how to give reasons to back them up, investigations, how you treat this patient, you prognosticate. Tell them the prognosis. Yeah, it's a better prognosis, depending on, if you don't know what to say, it depends on when the child comes to the hospital, because we are in Nigeria and late presentation is usually a matter of bad prognosis. No matter how simple the disease is, as simple as severe malaria, some of them go to chemist shop and do a manner of rubbish. By the time they are presenting to the hospital, it's already late, and you can do little or nothing to salvage the child. So just, if you don't know anything to prognosticate, just tell them time of presentation. Counsel the mother. If there is anything you find in your history, counsel it. And tell the examiner that I counsel the mother on. If you don't know any other thing, tell them that you're counseling on sleeping under insecticide treatments. Of course, I live in a malaria endemic environment. And most patients and their mothers don't sleep under mosquito nets. So you have to counsel them. So these are the sequence that I can use so that you'll be very, very thorough when picking a long case. I hope this helps you. Thank you. So guys, we just took lights, but I have to finish this video. I don't want to procrastinate. So the other point I'm going to talk about is past questions. Past questions help me to understand how the examiners think, and I noticed patterns, and I noticed that certain topics kept on coming up. And of course, before you go for any exams, you must know these high-yield topics. And these past questions that will review these high-yield topics to you, right? So they're like the examiner's favorites. So I didn't use past questions to memorize answers. Right from my UTME days, I always use past questions. After reading a particular topic, I try to go through past questions and know questions that have been asked on this topic and see whether I can attempt it. I use past questions as a learning tool. So if I couldn't answer a past question properly, it wasn't a failure, it was just a direction. So it told me exactly what to go back and read. Sometimes when I'm reading, I tend to miss out on things. But when I go to past question, I'll see that this particular thing I missed out was actually tested. I have to go back and go and read that thing I missed out on. So over time, my weak areas became fewer and my answers became sharper and more structured. Past question also taught me how to write answers. I learned how much detail was expected, how to structure responses, and how marks are being scored. Because sometimes, when you ask questions in past questions, sometimes they just tell you this is 5 marks, this is 10 marks, this is this, that. So it tells me where I should focus more on and stuff like that. By the time my name was approaching, the question didn't feel funny, and I'll be like, I've seen the abilities before, that kind of thing. So in pediatrics, past questions are not shortcuts, they are rather roadmaps. If you see them and use them well, they will show you where to focus on, how to think, and how to present your answers in the way the examiners will reward. So please, I'll always talk about past questions, even in my subsequent videos for obstetrics and gynecology, and of course for community medicine. Past questions are very, very crucial. Okay, the next thing I'm going to be talking about pediatrics is don't miss your postings. And even if you have to miss postings, let it not be chronic, if you understand what I mean. Now, what going to postings help you is that it helps you to start reasoning like the examiners. Now, let me tell you one thing I noticed about pediatrics consultants. Their ears, their whole sense organs, their eye, their nose, their mouth, their ears, everything is sharpened. Like, if I make a single mistake, they will catch you. For instance, how can you tell me that? And even as students, we notice these things, and if you say it, you'll be like, how? Because there's this thing we usually do when you collect these cases, and you allow your classmates to criticize or critique the case that you collect. Then a lot of persons are picking out different things, and even you yourself, you didn't even know that you missed out on. I'll give you an instance. It is a taboo for you to say that a 3-year-old child has headache, even if the mother tells you that the child has headache. How? Headache is subjective, and it's only what the child tells you that you will be like, oh, the child never told you that he has headache. And it is a taboo for you to mention it to the hearing of the pediatric examiner that a 3-year-old child has headache or is complaining of headache. Your failure has started. Or you say a 3-month-old child had convulsion associated with chills and rigor. How will a 3-month-old child have convulsion associated with chills and rigor? How will this child have rigor, 3 months, or chills? You might not know these things if you don't go for your postings. So when you go for postings, you start using it like your examiner because they tend to collect you. You will notice where they are heading to, what they're actually thinking, and you catch these things early. So guys, if you're looking for a distinction in pediatrics, please don't miss postings. And try as much as possible to go to other units. I was literally everywhere. I had close to 25 consultants, like lecturers in my pediatrics, and each of them know me. And apart from classroom, they knew me from clinic as well, because I was literally going to their clinic, their ward rounds, their calls, jumping from one place to another. To the point that before my examination, my friends were already asking me, also, what does this lecture, if I do this lecture in one case, what would this lecturer want? What would this other lecturer want? Because I feel like I've clicked and presented to most of these consultants over and over again. So at some point, I knew what they like asking or what they like testing. So please guys, don't miss your posting and try as much as possible to update. It should be very soon. Okay guys, they brought the light back, so let's continue. So the last thing I'm going to be talking about in this video is to give you tips for your OSCE. OSCE is the Objective Structured Clinical Examination. So what are you expecting in your OSCE? If you have this in mind, you will know how to prepare for it. So your OSCE will always be a history taking station. So you take history, you always have an examination station. There's always an examination, either abdominal examination, a CVS examination, examining the precodium, or a respiratory examination, or just anything, or any part of CNS examination. So just learn your examination very well, system by system, because examination will be there. There'll be a counseling station. In counseling, you can counsel on anything, counsel a mother on exclusive breastfeeding, counsel a child that is undergo blood transfusion, counsel on maybe a diagnosis, let's say malignancy, like glioblastoma, lymphoma, whatever. They just tell you to counsel the mother. You can just counsel on anything. So always remember that the counseling are usually going to be GADA. There are different counseling methods. We have the GADA method. Grades, ask, tell, help, explain, repeat. Right? That's what they usually use to teach us. So if you don't know anything, just follow the GADA method. You always never go wrong. But then you have to understand the concepts you're counseling about. Like if you don't understand it, why would you not counsel? So yeah. Then you must know your field. Very important. All those fields that you use in your station. And the only place you learn it is if you go for your chair postings. Chair is one place you should never miss out on. So know how those fields are given, the components of those fields, how they are used, what are the cases they are being used, and all those things. All those are 5% dextrose water, 10% dextrose water, mannitol, Vengas lactates, all of them. Please learn this field. You will see instrumentation. There are a lot of instruments. NG tube, oxygen cylinder, oxygen concentrator, nebulizer, cannulas, film manometer, blood giving sets, infusion giving sets, and blood bag, solu sets, all those MRDT, whatever. Sample bottles, urine dipstick, that of the 9-pack, tongue depressor. Some people will see tongue depressor, but you don't even know what tongue depressor is. Bag, mask and valve, catheter, flow meter, PMDI, stagiometer, spacer devices, chest tube, emergency tray, all those things. You must try as much as possible. And just take your time. Like, I took my time to learn them. And it really helped me a lot. Like, whenever I was getting to my OSCE stations, like, there were really questions I was expecting. They are genuine, how do you call it? Genuine question and the genuine question. Please, people should attend me, but that's usually what they used to say it in our school. Genuine question is associated with each of these instruments. Like if you're talking about NG2, obviously you should know how to know the correct, how to verify that you correctly placed the NG2 correctly. You understand? The complications, the indications, the contraindications, and all those things. So just know those genuine questions and whatever. Then you have the management question where they'll paint the case for you to make a diagnosis and tell them how you manage the case, right? Then there'll be a Viva question, a Viva station. Yeah, Viva can come from anywhere, so it depends on how well you are read. Then there'll be a procedure station. So pay attention to procedures that are carried out in pediatrics. All those urethral catheterization, blood transfusion, writing orders like blood transfusion order, all those things, and whatever, all the procedures that you know about in pediatrics. The common one, especially those ones that house officers used to do, even as common as how do you do random blood sugar, how do you check for random blood sugar, and how do you check for malaria parasites using MRDT kits, and how do you perform the analysis. I remember in one of my exams they asked me how I perform the analysis as part of the procedures. So yeah, so you must learn those things. Then basically that's just that. So common things appear commonly. Just know the common things in your teaching hospitals and you'll be fine. So in my other videos I'm going to be talking about how I make distinctions in obstetrics and gynecology and community medicine. But for this video, this is pediatrics. Please, if you have not subscribed to my YouTube channel, please subscribe to my YouTube channel as I'm going to be posting more relatable content. I'll help you guys. Bye.